Great. Okay, so welcome everyone. My name is Amy Harris, and I'm the manager of the Patient-Centered Primary Care Home Program. And I really appreciate you joining us today for this presentation in our webinar series about the upcoming standards that will be implemented in 2025. So today I'm going to turn it over to my colleagues who are going to talk to you and present about PCPCH Standard 2A, which is Performance and Clinical Quality. So I will hand it over to them.
Great, thanks, Amy. Good afternoon, everyone. I'm Becky Velasco. I'm a verification specialist with the Patient-Centered Primary Care Home Program.
And I'm Alicia Tavares, also a verification specialist with the program.
Thanks so much for joining us this afternoon for our webinar on PCPCH Standard 2A. First, let's go over a few webinar logistics and Zoom etiquette reminders. This webinar will be recorded and uploaded to the PCPCH program website. If you're having any technical difficulties, please private message Amy Harris for help. If you feel comfortable, please have your camera on and put your name and organization info up. And any questions or comments you have can be put in the chat, and we will address them during the question and answer session at the end of the presentation. Here's the agenda for today's webinar. I'm going to start by providing a brief overview of the 2025 PCPCH recognition criteria. Next, we'll do a deep dive into PCPCH Standard 2A. Then we'll share additional PCPCH resources and upcoming learning collaboratives. And last, we'll have some time to take your questions. The Patient-Centered Primary Care Home Program was established in 2009 by the Oregon legislature as part of the state's broader health system transformation strategy to improve access to care, reduce costs for patients, and improve population health. The standards are developed in partnership with an advisory committee and have been revised 5 times since 2009. The 2025 PCPCH standards were developed to support OHA's strategic goal of eliminating health inequities by 2030. The standards specifically help primary care practices build their capacity and processes to address inequities in their patient population. All practices applying or reapplying for PCPCH recognition after January 1st, 2025 must meet these new standards. For more information, I would encourage you to watch the recording of the 2025 PCPCH Standards Overview webinar, which is available on our website.
Today I'm going to review PCPCH Standard 2A. As you will see, the changes made to this standard are directly aligned with OHA's commitment to eliminating health inequities. PCPCH Standard 2A is in core attribute number 2, which from the patient's perspective means take responsibility for making sure we receive the best possible care. The intent of Standard 2A is that measuring and improving on the quality of clinical primary care services is a foundational aim for PCPCHs. The intent of this standard is to ensure that PCPCHs are monitoring clinical quality data and using this data to improve their performance where appropriate. In addition, this standard encourages practices to identify patient subgroups that are experiencing disparities in access or utilization of primary care services and to work towards closing these gaps where possible. It is important that practices monitor clinical quality measures and disparities that are meaningful to their patient population as a whole. Standard 2A is a check all that apply standard. That means you may attest to all of the measures that describe your practice's activities. There are 4 measures and a total of 30 possible points in the new Standard 2A. This is up from 3 measures for a total of 20 possible points in the current 2020 version of the measure. The measures in Standard 2A are as follows. The first is measure 2A0. PCPCH tracks and reports to OHA 3 primary care quality measures. This is a must-pass measure worth 0 points. The second is measure 2A1. PCPCH tracks and reports to OHA disparities in 3 primary care quality measures. This measure is worth 5 points. The third is measure 2A2. PCPCH tracks, reports to OHA, and demonstrates a combination of improvement and meeting benchmarks on 3 primary care quality measures. This measure is worth 10 points. The last is measure 2A3. PCPCH tracks, reports to OHA, and demonstrates improvement on disparities in 3 primary care quality measures. This measure is worth 15 points. Please note that practices are required to use the same 3 quality measures for all of the standard 2A measures they attested to.
Great. Now let's move on to reviewing the specifications for measure 2A0. A practice is meeting measure 2A0 if it tracks at least 3 primary care quality measures from one or more of the qualifying quality measures lists and reports its current performance, numerator and denominator, on these measures to the OHA via the PCPCH online application. The quality measures selected must reflect the various types of patients served by the practice. For example, a family practice clinic should monitor both adult and pediatric quality measures. In addition, the data collected to calculate performance on these measures must be aggregated across all relevant providers and patients in the practice. For example, if a practice selects a quality measure from the CCO performance metric list, they must track data for all applicable patients at the practice, not just Oregon Health Plan members. The qualifying quality measures lists are lists of primary care quality measures provided by select measure stewards that PCPCHs may choose from to meet PCPCH Standard 2A. Links to all of the qualifying quality measures lists can be found in the TA guide. The range of quality measures practices can choose from is significantly expanded under the 2025 standards. Available measures include CCO incentive measures and state quality measures, the CMS Children's and Adult Healthcare Quality Measures, the FQHC Uniform Data System Quality of Care Measures, and several more. Practices should use the specifications provided by these health authorities to calculate the numerator and denominator for their selected quality measures. Practices are responsible for ensuring that they are using the most up-to-date specifications available for their selected measures. There are several ways practices can choose to collect data for their selected 2A0 quality measures. First, they could query an electronic medical record system. They could perform a manual chart audit of at least 30 patient charts, or they could use quality measures produced from claims data by a third party, such as an independent practice association or health plan. If you select this third method, please ensure reports include data from all applicable patients at the practice and not just members of a particular health plan. For each quality measure, practices using a query or third-party claims data must include in the sample all relevant data from the last 6 or 12 months, with at least 30 patients included in the denominator. Samples drawn via manual chart audit must include at least 30 patient charts randomly drawn from all relevant patient charts in the last 6 or 12 months. Practices only attesting to 2A0 are advised to include data from the last 12 months instead of the last 6 months for each quality measure. Practices attesting to multiple measures in this standard must use the same 3 primary care quality measures for each one and ensure that the measurement period used to calculate current performance for 2A0, either 6 or 12 months, matches that used to calculate current performance for 2A1, 2A2, or 2A3. As you're completing your PCPCH application, we strongly recommend you gather and save all documentation that would be needed for a site visit. At a site visit, you'll be required to show this documentation to the PCPCH program to demonstrate you're meeting the measures. For measure 2A0, you would need to provide a copy of the specifications used for each of the 3 quality measures, including the name of the qualifying source or measure steward. Please note that the 3 quality measures demonstrated during a site visit must match those selected in the online application. You would also have to provide the data used to calculate the practice's current performance, so the numerator, denominator, and resulting percentage for the 3 selected quality measures.
Let's take a closer look at measure 2A1. First off, please note that this new measure 2A1 is replacing the current measure 2A1 under the 2020 standards, which has to do with value-based payment arrangements. This is because value-based payment arrangement measures are being moved to their own separate standard, Standard 2B. Now on to specifications for the new measure 2A1. A practice is meeting 2A1 if it is meeting the specifications for 2A0 and can identify 1 or more patient subgroups that are experiencing health disparities in the practice's 3 primary care quality measures. Patient subgroups may be defined by characteristics such as race, ethnicity, language, disability status, gender, gender identity, sexual orientation, age, special or complex health needs, social class, geographic region, life circumstances, health-related social needs, or other characteristics relevant to the practice's patient population. Health disparities can be defined as differences in the presence of disease, health outcomes, or access to healthcare services between various populations that are not due to differences in healthcare needs or patient preferences. In the context of PCPCH Standard 2A, disparities refer to a difference in a PCPCH's performance on primary care quality measure between 1 or more patient subgroups and its general patient population. Here are a couple of examples of activities that demonstrate successful implementation of Measure 2A1. A practice is tracking 3 primary care quality measures: diabetes, HbA1c poor control, colorectal cancer screening, and cervical cancer screening. The practice can segment its performance data on each of these measures by race. In doing so, the practice identifies 1 racial subgroup of patients that are being screened less for colorectal and cervical cancer than the average patient, and other racial subgroups that is experiencing higher A1C levels than their average patient with diabetes. A practice is tracking 3 primary care quality measures and is able to pull out and review its current performance data for rural patients specifically. In doing so, the practice identifies that its rural patients are experiencing worse outcomes among these measures than non-rural patients. At a PCPCH site visit, you would need to provide the following pieces of documentation to demonstrate that you are meeting Measure 2A1. First, a copy of specifications used for each of the 3 quality measures, including the name of the qualifying source or measure steward. Please note that the 3 quality measures demonstrated during a site visit must also match those selected in the online application. You would also need to see the data used to calculate the practice's current performance for the 3 selected quality measures, including a breakdown or summary of the disparities experienced by 1 or more patient subgroups.
Next, let's take a closer look at Measure 2A2. Please note that this measure is currently listed as 2A3 under the current 2020 standards. Under the 2025 standards, it is being reduced in value by 5 points to make room for the new measure 2A3, which we'll be discussing shortly. Now on to the specifications for the new measure 2A2. A practice is meeting measure 2A2 if it is doing all of the following. It's meeting the specifications for 2A0. It has improved on at least one of its 3 selected quality measures for which it is not yet beating the benchmark at its baseline in the last 6 or 12 months, and has demonstrated this in the PCPCH online application by providing its baseline, improvement target, and current performance. And it either meets a benchmark or can demonstrate improvement on the other 2 quality measures. When demonstrating improvement, the measurement period chosen to calculate the practice's current performance must match that chosen for 2A0, either 6 or 12 months. This means that in the PCPCH online application system, the current performance reported under 2A2 for a given quality measure must match the current performance reported under 2A0 for the same quality measure. Because the current performance will be compared to a baseline, the total data measurement period will include either the past 24 months of data, a year-by-year comparison, or the past 12 months of data, a 6-by-6 month comparison. For each of their 3 selected primary care quality measures, a practice should refer to the benchmark provided by the qualifying measure steward. The approved list can be found in the TA guide. If a benchmark is not available through the original measure steward, then practices should select a benchmark from the following sources in order. First, the CCO performance metrics, that is the CCO incentive measures and state quality measures. And second, a benchmark provided by a relevant health authority, such as Healthy People 2030. If not using the original measure steward benchmark or a CCO benchmark, practices must be able to demonstrate why the benchmark they chose makes sense for their patient population and meets the intent of the standard. As we discussed, this measure requires that you demonstrate improvement on at least one of your 3 selected quality measures for which you are not already meeting the benchmark at baseline. What constitutes improvement for a practice will depend on its baseline performance and an improvement target that is unique to the practice. Practices must calculate their baseline, improvement target, and current performance. To calculate your unique improvement target, you'll need the benchmark for the selected quality measure and your baseline percentage score. You'll calculate the target using the formula displayed. Next, compare your current performance to the improvement target. If your practice's current performance meets or surpasses your practice's improvement target, you will have successfully demonstrated improvement in the quality measure. These calculations are all listed in the PCPCH TA guide. Here's an example of how a clinic would calculate their unique improvement target for a quality measure. Ladybug Clinic is tracking oral evaluation for adults with diabetes using the CCO metric specifications. They calculate their baseline performance on this measure as 22% and see that the current CCO benchmark is 31%. First, they would calculate their X value as the measure benchmark, which is 31%, minus their current performance, 22%, and then divide the result by 10. Their X value is 0.9%. Then they would add 0.9 to their current performance, which is 22%, to get their unique improvement target for the measure. In this case, the practice's unique improvement target for oral evaluation for adults with diabetes is 22.9%. To determine whether they are demonstrating improvement, Ladybug Clinic would compare this number to their current performance rate. If their current performance is 22.9% or higher, they have successfully demonstrated improvement on the quality metric. At a PCPCH site visit, you would need to provide the following pieces of documentation to demonstrate that you are meeting measure 2A2. First, a copy of the specifications used for each of the 3 quality measures, including the name of the qualifying source or measure steward. Please note that the 3 quality measures demonstrated during a site visit must match those selected in the online application. If they're not included with the specifications, you would need to provide a description of the benchmarks used for each quality measure. Third, you need to provide the data used to calculate the practice's current performance. So that is numerator, denominator, and resulting percentage for the 3 quality measures. And last, you'd need to provide the data used to calculate the practice's baseline and improvement targets for the quality measures that the practice has chosen to demonstrate improvement on. If the practice chooses to demonstrate improvement over the last year, it will need to show 2 years of data. If the practice chooses to demonstrate improvement over the last 6 months, it will need to show 1 year of data. As you have seen, Measure 2A2 is a technically complex measure, so please be sure to thoroughly review the complete measure specifications before attesting to it.
Finally, let's review the specifications for PCPCH Measure 2A3. A practice is meeting Measure 2A3 if it is meeting the specifications for both 2A0 and 2A1 and can demonstrate that it has improved on health disparities in all 3 of its quality measures in the last 6 or 12 months. The patient subgroup selected for disparity reduction should be meaningful to the practice's mission or reflective of its patient population. Practices may choose to align their improvement efforts with existing goals, such as those suggested by local CCO community health assessments, or to focus exclusively on their unique patient population. Additional guidance around identifying disparities can be found in the specifications for 2A1. Improvement can be demonstrated in either of the following 2 ways. First, a positive change in the practice's performance for a specific patient subgroup, or a reduction in the gap in the practice's performance between a patient subgroup and the rest of the patient population. The gap reduction must be due to a positive change in the subgroup's performance, not just because the performance along the comparison patient group worsened. While this is technically a reduction in the disparity, it would not count towards Measure 2A3. And please note the data used for the comparison must span either the most recent 12 months, comparing the most recent 6 months to the 6 months before, or the most recent 24 months, which is comparing the most recent year to the year before. Here are a couple of examples of activities that demonstrate successful implementation of Measure 2A3. A practice is tracking 3 primary care measures: diabetes, HbA1c poor control, colorectal cancer screening, and breast cancer screening. It identifies in its performance that a couple patient subgroups are being screened less for cancer and experiencing higher A1C levels than their average patient with diabetes. Since Latino and Latina patients make up 10% of their patient population, they decide to take steps to close the gap for this subgroup. They are able to demonstrate that over the past year, they closed the gap between their Latina patients and the rest of their patient population by 1% in colorectal cancer screenings, 0.5% in breast cancer screenings, and 3% in A1C poor control. Here's another example for 2A3. A solo practice is tracking 3 primary care quality measures: depression screening, oral evaluation for adults with diabetes, and cervical cancer screening. It has identified that its rural patients, of which it has at least 30 patients, are being screened less for depression and oral health than its non-rural patients. It has also discovered that its patients who identify as LGBTQIA2S+ are being screened less for cervical cancer. The practice takes steps to reduce barriers to care for its rural patients and LGBTQIA2S+ patients, and is able to demonstrate better screening rates among these groups over the last 6 months. At a PCPCH site visit, you would need to provide the following pieces of documentation to demonstrate that you are meeting Measure 2A3. First, a copy of the specifications used for each of the 3 quality measures, including the name of qualifying source or measure steward. Secondly, we'd need to see the data used to calculate the practice's current performance for the 3 selected quality measures, including a breakdown or summary of the disparities experienced by 1 or more patient subgroups. The data should reflect the last 6 or 12 months. And lastly, the data used to calculate the practice's baseline performance for the 3 selected quality measures, including a breakdown or summary of the disparities experienced by 1 or more patient subgroups. This data should reflect the last 6 or 12 months directly preceding the current performance period.
So that ends our presentation on Standard 2A. The PCPCH program is hosting several other webinars this year to help partners and practices. Webinars are scheduled every other Friday through December. You can find a complete list of topics and registration information on our website. The next 3 webinars are listed on the slide. I hope you'll join us, but webinars will be recorded and posted on our website if you can't make it. This final slide is additional resources that you may find helpful. The first is our PCPCH program website. The second is the 2025 TA guide with detailed information about how to implement every measure and the documentation requirements. Next is a link to our TA resources webpage. And finally, the community engagement report and evaluation. You're always welcome to reach out to the PCPCH program with any questions through our program email.
Great. Thank you so much, Becky and Alicia. I know that this is, as Becky noted, this is a pretty complex measure or standard. So we did spend a little bit of extra time going over some of that detailed information about how to calculate it. So I hope folks found that to be helpful, even though it's probably a little bit more in the weeds than what we usually get in these webinars, but I hope that folks found it to be helpful. So it looks like we have a couple questions in the chat. Let me open it up a little bit better. Okay, so it looks like Robin asks a question related to 2A1. She's asking if there's a minimum recommended threshold for the disparity in order to qualify for use in the attestation, meaning, in other words, does the subgroup's performance have to be 5% lower in the comparison group? And the answer to that is no. We don't have any minimum threshold requirements for the disparity. This is a new measure. We might in the future consider that. But for right now, we really just want practices to be looking at their data, identifying patients that have disparities, and thinking about what actions they can take to improve that. We also know sometimes within certain groups, there could be a really small numerator, right? And so it might not make sense to have a minimum percentage. We just really want practices thinking about what those disparities are in their patient population and how they can address them. And then her additional question about 2A1 is that does the clinic need to identify one patient subgroup experiencing disparities across all 3 primary care measures being tracked, or could they use 3 different subgroups that are experiencing disparities in one of each of the tracked measures? And it's the second one. You don't have to use the same subgroup of patients. You can use different subgroups of patients. You do have to use the same measures or the same quality measures throughout the standard, but you don't have to use the same subgroup of patients. So you could have a patient subgroup that you're tracking by age, and for one measure, and maybe you have an age group that isn't doing as well, and in another you might have a disparity that you see among a different race within your patient population. So it doesn't have to be the same patient population subgroup. That's a good question. Let's see. Okay, and then another question from Robin. Good, thanks, Robin. So it says, does the identified patient subgroup selected for the disparity reduction need to have 30 plus patients in the denominator to qualify for attestation? So that, I think I kind of answered that before. So the answer is no, because we do expect that there will be some of those denominators that are actually quite small. And so again, as long as you are able to identify the disparity in your patient population and do something to address it, that would, I think, meet the measure. I don't know if, I mean, there could be potential times where it could be challenging to do the calculation, but I don't know. I guess I would refer to our team to see if they have any input on that minimum number. I don't know, Rachel, I know you've been around in the data a lot for this measure.
Yeah, I mean, I would recommend, especially if you're doing a chart audit, we require a minimum of 30. And so if a chart audit is being used, we'd probably want to see that. But in general, we don't have like an official minimum. I think we would recommend choosing to highlight or focus on disparities that are meaningful. So for example, that could mean different things. That could mean the amount of patients that belong to that patient subgroup. Meaningful could mean how big the disparity is. So if like one subgroup is experiencing a disparity of 1% and another subgroup that's larger is experiencing a disparity of like 15%, then that might be something to consider on which disparities you want to highlight or focus on.
Thanks, Rachel.
Can I just add to that the quality measure that you're starting off with, that needs to have at least 30 patients. I don't know if that's helpful just to kind of add.
Yep. Yes, thank you. And someone asked which practice Robin works at. Robin works at Providence. So we've known Robin for a long time. So okay, let's see here. Okay, so somebody's just commenting. Great. Great. Chris is saying that they're glad to hear that there's not a minimum threshold. Great. Oh, and yep, Robin, I see you added Providence on there. Great. Those are all the questions in the chat. Are there other things folks want to ask about this standard? You could unmute yourself if you want to, or put it in the chat. I know when our standards advisory committee met to talk about this standard and revisions to this standard, they were pretty excited about it, just about the opportunity. Again, like I said a couple of minutes ago, to really just give practices some guidance on how to look at their data in a way to identify disparities and think about like, what are those gaps? Who are those patients in your practice that maybe aren't getting the same level of care or the same level of outcomes that the rest of your patient population is getting, and what can you do to kind of help that or change that? And so so the committee was pretty excited to put these changes into place, and we hope that although it is technically complex with some of the calculations, that it feels meaningful for practices. It feels meaningful as you're implementing it and thinking about it. And know that if you have questions about it, about how to do the calculations or about which, again, about the specifications, you can always reach out to us. Rachel is the person, when you email, she's the one who responds to your email messages, and she does a really great job at either answering your questions directly or finding someone else on our team who can answer it. And we do our best to know the answers. I mean, I'll just say these are also new standards for the most part for us as well. And while we did have a lot of community partner input when we were developing the specifications, a lot of practices helped us, a lot of subject matter experts, there's still things we might not have caught or still things we might not have considered. And so that's why it's great that when you ask us questions, it just helps us to think about the standards in a different way as well, and maybe think about things we may have missed. So never feel like you can't reach out and ask us questions. So. Anything else folks want to add or ask? Okay. Well, then I'll just thank you again for coming today, and I hope everyone has a wonderful holiday weekend. And I hope that you'll join us in 2 more weeks when we'll have our next one in the series. And this will be recorded and uploaded to our website, and we'll make sure and send out the slides deck to everyone as well. So again, thank you so much. Have a great weekend, everyone.
Bye.